to dental practitioners and parents. Although with training, you should be able to detect malocclusion in the primary dentition, there's no doubt that the Myobrace for kids and Myobrace for teens, it becomes a lot more obvious for dental practitioners and parents. Now, the most frequently used appliance range by far is the Myobrace for kids. And the reason that the Myobrace for kids is the most commonly used is because the children are early enough to be growing and developing correctly, but old enough to be able to comply well with treatment. And also it's a great age to treat, as you can set the foundations for the developing permanent and the permanent dentition. So the Myobrace for kids appliances, we try to simplify everything at MRC, so it's sequential. You can't just be using one appliance. You can, but it doesn't really give you the full result. The entire myofunctional orthodontic protocol involves the entire Myobrace appliance sequence for that range. So Myobrace for kids is a 3-stage appliance sequence, K1, K2, K3. There is another appliance called the K0, but I understand that some doctors are pretty new, so I won't be talking about the K0 in great detail just in this presentation, but you can find out more information about the K0 on our website. So if you notice here, the K1, the stage 1 appliance here for habit correction, K1, it's designed to create initial breathing and myofunctional habit correction. Once we've done that, we move on to the K2, which is the 2nd stage for arch development. And this is designed for arch development and continued habit correction. Once we're done with these goals, once we've created arch development and corrected the habits, we then move on to stage 3, which is designed for final alignment and retention. Now, in the previous webinar that I spoke to you guys about, the introduction to myofunctional orthodontics, we discussed why that appliance sequence is important if you're going to be providing myofunctional orthodontic treatment. So as we know, myofunctional orthodontic treatment aims to correct malocclusion by looking at the underlying breathing and myofunctional causes. So if we're going to be providing cause-based treatment, we really want to be starting here at correcting breathing, then the habits, then provide arch development, and then provide alignment and retention. If this doesn't make sense to you, please go back to our previous webinar where we talk about why this is the sequence of myofunctional orthodontic treatment. So at the beginning of treatment, we're really looking at correcting the breathing and the habits. And that's exactly what the K1 does. Okay, so that's why we use the K1. Once we've done that, we move forward to the next stage, the 2nd stage, K2, which looks at correcting the habits and providing arch development. Okay, so we need to provide arch development to make more room for the tongue, to align the teeth, to create better facial development, and then allow the tongue to then grow and develop the jaws in the correct way. So it's very important that we use the 2nd stage appliance. There's some doctors around the world that are just using the stage 1 appliance and they're not moving on to the stage 2. My advice to those doctors is if you're not using the stage 2, you're not doing the majority of treatment. So in our clinic, we use the K1 for anywhere between 3 and 6 months, sometimes even less. Really no more than, I mean, we'd be asking questions if the patient wasn't ready to move on after 3 months. Then after that time, we go on to the K2 and the patient remains in the 2nd stage appliances for the majority of treatment. Okay, so it's very important, the 2nd stage appliance. Then finally, once we're done with the arch development and habit correction, we move on to the 3rd stage appliance, the K3, which is designed for final alignment and retention. So what do we mean by final alignment? When you're done with the K2, generally about 90 to 95% of the alignment is already done. So you can switch to the K3 at that stage to get that final alignment and then hold the teeth, the arch form, and more importantly, the habits during the retention period. So the retention appliances are very, very important. And so I'd just like to follow up with a case here. So this is a patient that was 9 years old when they started with us. We can see here a narrow arch form, malocclusion lower arch, a large overjet, and we can clearly see here a lip trap, a deficient mid face, deficient lower face. You can just see overall myofunctional problems here are quite evident. The patient had a reverse swallow as well and a low tongue position. We can see the tongue clearly doesn't fit up there in the roof of the mouth. So just by using our Myobrace appliance ranges, so we started in the K1 and we moved the patient through the sequence. He did end up in the T series because he sort of aged throughout treatment. And this was his most latest treatment photos. And we can see here, he went from having the overjet corrected, almost corrected in a year, just by using our appliances. And then throughout this time, we put him on long-term recall visits and he kept wearing his appliances. And then he came back and we this is the way he looked at the end. So we can see here the overjet is more or less corrected, and when we look at the arch form, it's looking nice here, and we've got plenty of spacing for the permanent teeth to come through. Now, whenever you're treating these class 2 patients, you might get some spacing here in the lower arch. Don't worry about that, that closes over time. The important thing is that we have excess space now for all of the adult teeth to come through, and we have enough space here for the tongue to sit in the roof of the mouth as well. So this is just an example of what you can do with Myobrace only. Okay, here's an example of his facial development. So you can see at the front here, the smile is looking much nicer. The lip trap has been eliminated. And when we look at the profile, the face is developing nicely as well. And you can see the difference here in the mid-face development. So this isn't a result of the Myobrace pulling the jaw forward. It's a result of correcting the habits and allowing the habits to bring the jaws forward into a nice alignment. And we can also see here, with establishing nasal breathing, we can see some good mid-face development as well. Okay, so here are the complete photos, and the patient remains on retention visits until his second molars are erupted, and then we have a discussion about long-term retention. Okay, so that gives you a gist of the K series. So that's pretty much all you really need to know at this stage about the K series. We do combine the K series sometimes with arch development and other techniques and so on. But for the majority of cases, you can just go K1, K2, K3, and combine with the Myobrace activities as well. Okay, so now we're going to move on to the Myobrace for teens. And the Myobrace for teens is the second most popular appliance range. And the reason the Myobrace for teens is a second most popular range is that really at this age is when patients start to become conscious about their teeth, the crowding of their teeth. This is really the orthodontic age of treatment. So the Myobrace for teens is a 4-stage appliance sequence. And the reason it's a 4-stage appliance sequence is, as we mentioned, it's the orthodontic age group. So that means really at this age, growth and development is slowing down. Habits are only going to help develop the jaws so much. So we're really focusing more on dentoalveolar correction, and still some jaw development is remaining, but you know, it's limited, the amount of correction that you can get at this age. So we're mainly focusing on dental alignment, but also as a result of that, there's 3, the Myobrace for teens stage 3, which is just focusing on dental alignment. Okay, so it's a specific specialized appliance. It's just focusing on dental alignment. We'll talk about that more in just a second. So again, we go back through the sequence. The T1 is for initial breathing and myofunctional habit correction. It's pretty much the equivalent of the K1, but in the T series. Then the T2 is for arch development continued habit direction. It's pretty much the equivalent of the K2, but in 3, because the T4 is for final alignment and retention. But before we get to the T4, we use the T3 because that's for dental alignment, and this is the orthodontic age group, because we really want to get those teeth aligned as nicely as possible in this age group. Now, we also have another specialty appliance called the T1 BWS, and the T1 BWS is for combination with our bent wire system. It's our go-to arch development approach. So whenever we're using the BWS, we tend to use the T1 BWS in this age group. Now, we won't get into that today either. We may have another webinar on arch development in the future. But for now, we just want you to focus on T1, T2, T3, T4. Okay, and again, we go back through this exercise here. So the T1 is for breathing and habit correction. The T2 is for habit correction and arch development. And the T3 and T4 combine to provide correction and retention of the teeth. Now, we tend to tell patients to use the T3 for 2 hours a day and overnight, and unlike the other Myobraces that are 1 hour a day and overnight. The reason is that we want to be wearing this appliance as much as possible because it's acting like an aligner. But the other appliances are more myofunctional in nature. So let's take a closer look at the T3. Now, a lot of you are aware of some of the other companies making appliances that are in this domain. And most of these companies, if not all of them, are basically a equivalent of the T3. Okay, so they're looking at doing dental alignment and some habit correction, but mainly dental alignment. And we have the same system here, but the T3 is the equivalent of some of those other brands that I just showed you now. So these little 2 slots sit around the the T3. Is the size of the T3 that we select. And if you fall between one of the two lines, we always just go up the larger size. So place these arrows on this side here, then you wrap the ruler around whatever line this side falls on, we select. So let's say it falls around here. What are we here? We're between the 4 and the 5, so we would go with a size 5 for that patient. Now, the T3 has our technology that really MRC pioneered is the inner cage here. You can see there's an inner cage inside the T3, and that sort of helps to provide a little bit of arch development as well as dental alignment with the 2 slots. So some patients find the T3, because it pushes on their teeth, it's a bit more of a surprise compared to the T2. So as a nice transition appliance, we have another appliance called the T3N, which is a T3 with no core. There's no core inside this one. And we use this for a few weeks, say 2 to 4 weeks, to allow the patient to transition to this feeling, and then we move them onto the T3 for day and night. Okay, so what sometimes we do at our clinic as well is we issue the T3 during the day and we use the T3N at night. And then once the patient's accustomed to the T3N, we switch them to the T3 day and night. Okay, now some practitioners out there, if they're just looking for an appliance to just align the teeth, they can also issue just the T3N and then follow it up with the T3. That's an option as well. So there's plenty of different options that you can have. But really in our protocol, we like to go T1, T2, T3, T4. Okay, now here's the case for the T series. So this patient here is 13 years of age. The T series we tend to use between the age of 10 and 15. So this patient actually had a round of orthodontic treatment, and he was already relapsing after about 1.5 years, I believe it was. And he came in to see us again and he said, look, I don't want to go through that again and just relapse. So what can you guys do for me? We can see here he's got a narrow arch form. You can see the arch form is starting to collapse. There's some mild crowding of the upper teeth and flaring. And then we've got an overjet here and some mild crowding of the lower teeth as well. So this is the kind of case that I could treat with the T series without needing to do any sort of arch development. So what we did was we started in the T1, then we issued the T2 once nasal breathing had been established. You can see here that took about just under 3 months, I believe. Yep. So we established nasal breathing here, we issued the T2, and then the patient stayed in the second stage appliance for the majority of treatment. And you can see here in 1 year, the difference between the start and the finish here. So we can see just by using the T series appliances, we were able to achieve this result. So some of you may be saying, well, why don't you use the T3? We found that by the time we finished with the T2, we didn't even need any dental alignment, so we went straight to retention. Now, the T3 is the only time you can skip an appliance, if I'm to use that word. More often than not, we will use the T3, but sometimes you can say, well, if the dental alignment's okay, we'll just go to the T4. But you can't skip the T1, you can't skip the T2, and you can't skip the T4, okay? Because these are crucial in myofunctional orthodontics, whereas dental alignment is more of an orthodontic thing that we like to provide. Okay, and we can see the difference here in the overjet as well. A really nice correction of the overjet. You can see the deep bite has been corrected as well, and we've got excess spacing here, which will close over time too. Okay, so really nice way to get a good result in these kinds of cases. And here are the appliances in place. Okay, so here's the progress of the patient's profile. Again, we can see here the angle. I often like to look at this soft tissue angle here. So you can see it looks sort of like got that double chin look. And then you can see that's much better here. So this is a consequence of creating more room for the tongue and allowing those jaws to come forward slightly as a result of correcting that overjet. Okay, now just one thing you guys need to be aware of, I have mentioned it in this presentation, is the T series, a lot of the time, maybe 50% of the time, our development system. So in these sorts of cases, I'll just take you through the protocol quickly. If you're just getting started, don't worry about this. You're not going to be doing BWS to begin with. But for those doctors out there who have had training in the BWS or who've done our online course, we have an online course on the BWS that gives you really good training. For those doctors out there, this is the general protocol that we follow on the T series. So if I make the determination that a patient needs arch development, what we might do is, instead of starting with the T1, I can just start with the T1 BWS. It just saves you from buying an extra appliance. You just start with the T1 BWS, you establish nasal breathing, and then once you've established nasal breathing, then we move on and we issue the BWS appliance. Okay, so you can see a graphical representation of this. Again, if you haven't seen it before, go and do the online course or speak to your regional office to get some hands-on training. Then we put the BWS in, and then we put the T1 BWS over the top, and these two are actually used simultaneously to each other. And our arch development takes about 3 to 4 months, and we try to get the arch form to improve, like so, and keeping in mind that 50% of our expansion comes from the tongue. So if you've ever tried to use the BWS without using a Myobrace, don't do that, because it distalizes the molars and you don't get adequate expansion. You must use the Myobrace over the top of the BWS because it relies on the tongue to develop the arches. Okay, so once we've achieved our arch development here, we can remove the BWS, but we leave the bands on, and we also leave the stops on, but the graphic just got rid of them. I apologize about that. And what we do is we put the T2 over the top, okay, of the arch form. So by issuing the T2, we're able to maintain the arch form, and it can even just fine-tune the arch form towards as we're sort of as we're finishing with the BWS. So it fine-tunes the arch form, maintains the arch form as well with the T2. Okay, then we stay in the T2. We continue to stay as we're correcting the habits. Once we've corrected the habits, we're happy with the arch development. We remove the bands from the patient, and then we issue the T3 to create dental alignment. Okay, so we create dental alignment using the T3, and then finally from there we move to the T4 for retention. Okay, retaining the alignment and the habits. So here is a case that I wanted to show you guys that went through that sort of protocol. So this is a case here. We can see it's more than sort of anything mild to moderate between 10 and 15 years of age, mild to moderate arch restriction. Anything more than that, you might need to use the BWS. Mild to moderate arch restriction between the age of 10 and 15, you often don't need to use the BWS. You just use the Myobrace appliances like the previous case I showed you. In this case, we can see there's sort of moderate to severe arch restriction. So we made the determination here that this patient will need the BWS. We pretty much made that determination at the outset of treatment. We can see 100% deep bite and overjet, lips apart, mid-face deficiency, lower jaw deficiency, etc. So we can see this patient has a number of problems, crowding in the lower arch as well. Okay, so this was pre-treatment, and then we treated him with the T-series and BWS. 7 months after treatment, virtually we'd open the bite right up, so we'd corrected the overbite. Anyone doing orthodontics knows how difficult it is to correct deep bites, but we do it routinely in Myobrace treatment. And you can see we've got excess spacing here, everything's fitting in quite nicely. And then after 13 months of treatment, everything's settled in nicely as well. You can see the canines have erupted naturally into position. Okay, this was the patient's facial development. So his head's uprighted a little bit more, and his mid-face is looking much nicer. You can see that fullness in the mid-face, again, as a result of establishing nasal breathing and correcting tongue position and bringing better harmony in the facial harmony. Okay, and we look at the front as well. We can see the patient's bringing their lips together, no strain around the lips when he closes his lips, much more even vermilion borders. So this patient's looking much nicer. The mid-face as well is looking broader as well, and this is just in 13 months. Okay, that's where we started. And that's where we finished. And this was the protocol that we took. So we went T1, T2. We went in the T2 for a little bit just to see whether the patient would develop. The development was a bit slow for our liking. So we went to the BWS and T1. And then in 13 months, we issued the T4 for retention. And that's when the patient finished. Now, for anyone out there who wants to treat really difficult cases and they need to be finished off in braces, what you can do is actually replicate what I mentioned with the T-series and arch development. So T1 BWS, BWS plus T1 BWS, then T2. Then once you've gotten to that stage, rather than using the T3 for dental alignment, you could be using braces or clear aligners. And these are for the cases where let's say we have to do a canine exposure and we have to bring the canine down into the arch, or for example, there's a severely rotated tooth that we need to use braces or clear aligners. That's when we would use this protocol. Some doctors out there, they might just be more comfortable using braces and clear aligners. That's fine, but we highly recommend you start with the T-series before that. And what you can do is you can just speed up your arch development phase and get some habit correction happening from the outset of treatment. Now, anytime you're using the braces or clear aligners, we recommend you combine with the Myobrace for braces, and we'll talk about that in a second. We do like to combine clear aligners with the B3 appliance, but we've had a lot of people tell us that they prefer to use it with the B1, just because their patients report that it's slightly more comfortable. So you can use the B1 for clear braces and clear aligners, that's no problem. In the countries where the Myobrace for braces is not available, the T for B is also an option. So you can use the T for B. The Myobrace for braces is just the evolution of the T for B. It's just got slightly more precise features and creates better results. Okay, once we're done with the alignment stage, then we issue our bonded retainers as normal, and then we put our T4 over the top. Okay, so if we are going to be looking for long-term retention, so indefinite retention, we would need to use a T for A phase 2, and we typically use the large size, T for A phase 2 large, and we use that indefinitely. Okay, so for more information on retention, I'm not going to cover it today because this is a bit of a beginner webinar, an overview webinar. Please complete the online course, MBO 101. It has a great chapter on what you need to do for retention. Okay, so like I mentioned before, using this protocol speeds up your expansion phase and gets rid of half of your clear aligners because you're not relying on the clear aligners to create any arch development. Okay, so the next appliance series we want to talk about here is the Myobrace for interceptive class 3, the I3 series. Now, we usually talk about this range because a lot of doctors will come and ask us, like, what do I do for class 3? I'm seeing a lot of young kids in the primary early mixed dentition with class 3. How do I treat them with Myobrace treatment? And you absolutely can. The Myobrace I3 can be used between the ages of 5 and 12. However, it's most effective between the ages of 5 and 8. And the reason here is that with the class 3 cases, we're really trying to get the top jaw to develop forward. Okay, we're trying to develop that upper arch, get the tongue up in the roof of the mouth, and allow that top jaw to develop forward. Okay, because in class 3 cases, the tongue is often low and the top jaw is underdeveloped. So what we want to do is we want to use the I3 range to develop that top jaw forward, but the top jaw is much harder to bring forward after the age of 8 without using any sort of arch development. So in cases where we have a patient who's class 3 above the age of 8, we'll almost always use a BWS appliance to bring that top jaw forward so we can correct the class 3. In patients below the age of 8, we almost always combine the I3 series with the Myobrace technique. Okay, so if you don't know what the Myobrace technique is, please go on our website, go to myoresearch.com, appliances, arch development, and then there's a section called Myobrace. Click Myobrace, everything you need to know is there. If you go down to the bottom of the screen, you'll also find the Myobrace manual. If you just read the manual, I think it's 10 pages. It'll explain everything you need to know, from why we use it, how to apply it, and so on. So if you're going to be treating class 3, please read that manual, and then we just treat them using the I3 series. So we start with the I3N. The naming convention is slightly different, just because I3-1, I3-2, I3-3 it doesn't sound very easy to say. So we went with I3N, N stands for no core, I3, which is the second stage appliance, and then the I3H, okay, for hard. So that's the third stage appliance. And the principles are exactly the same as the K series. So I3N is the equivalent of K1, I3 is the equivalent of K2, I3H is the equivalent of K3. But most importantly at this age, you really want to be treating these kids between 5 and 8. Even earlier than that, we've got cases of 3, 4-year-olds that you have class 3 and we treated them with the I3 series. So that I recommend you do that, but then make sure that you learn the Myobrace technique. Don't be worried about the Myobrace technique. It's literally just composite buildups on the lower deciduous teeth. You guys already have the skills to do them. So read the manual and apply the Myobrace. So here's an example of a class 3 case. This girl's 5 years and 11 months old. We can see here class 3 underbite, mid-face deficiency, underdeveloped upper arch. And we issued the I3N at this stage. Then we applied the Myobrace. You can see the composite buildups here. And then we issued the I3, which is the second stage appliance. And after we issued the I3, there's the I3 there in place. You can see the patient's corrected their class 3. This is a number of years later. And the class 3 has remained corrected, okay? And the facial development's looking much better as well. Now, I don't want to confuse you guys with this slide here, but what I'm just trying to say with this slide is sometimes a patient can start in one series and move into the others. So as you guys have seen me say, like K1 is equivalent to T1, which is equivalent to I3N. So there's slightly different indications to use each one, but they are doing the same thing within that indication. So what sometimes happens is a patient can start in the K series, and then halfway through treatment, they might move into the developing permanent dentition. So they start at 9, and then they become 10 after a year. So then you might say to yourself, well, can I then move them into the T series? Well, you absolutely can. Okay, and this is the way that we do it. So for example, someone starts in the K1, and then they move to the K2, and then say the patient turns 10, and they're finished with arch development. You might then issue the T3 because you're trying to give dental alignment, and then go to the T4. Or let's say they're not finished with arch development, so they still have more arch development to do. So you can switch them from the K2 to the T2 and continue, okay, because it's the equivalent of the K2. Does that make sense? It's sort of like a, you can move patients between series depending on the indication. Similarly for class 3, so a patient may start as class 3, so you issue the I3N, then you go to the I3, and then halfway through using the I3, they might have corrected to class 1, but they still need some more upper arch development. So then you switch them to the K2, and then you continue as if they were class 1. Okay, so as long as you understand what the equivalent of each appliance is within the different series, you can make that jump, and we call that Myobrace cross-series compatibility. So if you go on our website and you notice, oh, why have they started in the K series and they moved into the T series? It's more often because of this reason here. Now, there's a number of features that allow the Myobraces to work the way that they do to correct the habits and so on. So I just want to play you this video here that explains the different features of the appliance. So the first feature that I want to talk about here is the tongue tag. And the tongue tag is very important because the tongue tag establishes the correct position for the tip of the tongue. So when the patient wears the appliance, and we're looking here from a posterior aspect, when the patient wears the appliance like this, the tongue, the tip of the tongue goes to this tongue tag, and it helps to establish the correct position for the tip of the tongue. So it teaches the child where to place the tip of the tongue. We have these tongue elevators which sit in the floor of the Myobrace, sit in the floor of the mouth, and they push the body of the tongue up towards the roof of the mouth, okay, so that the tongue can sit up in the roof of the mouth. And the tongue tag does the tip of the tongue, but the tongue elevator does the posterior aspect or the body of the tongue. The next feature here, which is very important, I believe no one else really has this technology except MRC, is the dynamic core. So our appliances allow you to provide arch development while maintaining comfort. So the outer layer of the appliance is a silicone, but the inside layer has the dynamic core. So it's still rigid, but it's comfortable for the patient. The way other people try to create arch development, other competitor products, is that they create harder appliances. And when you put these appliances in the mouth, they're just uncomfortable for the patient. So the dynamic core is a very important feature, and it's mainly in our stage 2 appliances. Okay, then we have the extended lip bumper, and every time the patient swallows, if they're using their lip muscles, which is dysfunctional, this lip bumper provides feedback to the lip and discourages them from doing so. Then we have the breathing holes, which make it difficult to impossible to breathe through the mouth. So the patient tries to breathe through their nose, and that's how we train nasal breathing. And then on top of that, we have these high sides, which hold the soft tissues away and promote arch development through the Frankel effect. So we're holding the cheeks away from the teeth and allowing the jaws to develop, assisted by the Myobrace and the tongue. Okay, every Myobrace appliance is worn for 1 hour a day plus overnight, and they all assist in correction of breathing and myofunctional habits. The only exception to the wear rule here is the T3 that's worn for 2 hours in the day plus overnight. So I get a lot of doctors asking me, well, when do I transition between the appliances? When do I go from stage 1, stage 2 to retention? So let's cover that here. Okay, so we're going to use the K series because it's the most popular appliance range. So we're going to use that as our example. If you understand the principles in the K series, you'll understand them for every Myobrace range. So starting with the K1 that's focused on breathing and habit correction. Why do we use a stage 1? The first reason for using a stage 1 is that it's a soft and flexible material, so it's the ideal introduction. I've come across some doctors, thankfully not too many, but some of them say we skip the stage 1 and we go straight to stage 2. I don't recommend you do that because it impacts compliance, but it also puts way too much pressure on the teeth to begin with, and it's gonna have trouble adapting to different arch forms. So putting that much pressure on the teeth may cause some adverse effects in the patient as well. So my advice to you is never skip the stage 1. We always start with the stage 1. And then we move to the stage 2 once the goals of the stage 1 are met. So we'll cover those in just a second. So why do we use a stage 1? Soft and flexible material, which gives an ideal introduction to the patient. it adapts to any arch form of malocclusion. So that's why our appliances are prefabricated. They can fit any child out there that you can see. So we use the soft silicon appliances because they can adapt to any arch form of malocclusion. It optimizes comfort as an entry appliance, which is crucial for compliance, as I mentioned before. Okay, so when do you progress from the stage 1? So when do we finish with the stage 1? So when the appliance is being retained overnight consistently over the month. So remember, we're seeing patients monthly in Myobrace treatment. So every month that the patient comes in, if in the preceding month, the patient may have retained their Myobrace appliance for at least 25 to 30 nights out of the previous month, that's when we start to say, okay, they're getting ready to move on. When the patients become a partial to full-time nasal breather, so they might come in, mouth open, mouth breathing, their breathing metrics are not too good, but then you notice that they're starting to improve. They're starting to close their mouth more when they come into your clinic, breathe through their nose more, their parents report they're breathing better overnight and so on. And then when the symptoms of mouth breathing are mostly resolved and continue to improve. So the symptoms of mouth breathing don't need to be 100% resolved, because sometimes you need more arch development to resolve the mouth breathing. But if they're resolving and the patient is retaining their appliance, we typically move on to the stage 2 appliances to get continued correction. Now, one tip I have for you is sometimes if you move from the K1 to the K2 is a lot more firm than the K1. So the patient might say, oh, it's a little bit uncomfortable, or some of the younger kids may have trouble adapting to it easily. So what we recommend you do, a little tip for you, is try to anticipate when you're going to be moving on to the second stage appliance. So you can typically do that. You can see the patient's trajectory getting better and better. So they might start out and they say, oh, I only retained my appliance for 10 nights in the past month. And then the second month, they might say, I only retained it for 20 nights. So you can make a prediction that the next month, if they continue to wear their appliance well, they're going to be retaining the appliance as per the recommended guidelines for moving on. So you can almost forecast that they're going to be moving on to the K2 in the next month. So what I would do is, or what our clinicians do here, is that 1 month before we progress to the K2, we issue the K2 for day only. So we tell the patient, here's your stage 2 appliance, wear this just for 1 hour in the day and keep wearing your K1 overnight. And if you keep doing well, and if you keep your Myobrace in it, most nights in the week, or most nights in the month, I should say, then we will move you on to the K2 day and night. So when the patient then comes back next time and they say, Dr. Emad, my appliance stayed in, pretty much every night this month, and everything's gone well, and I've worn my K2 during the day, then I might say, congratulations, well done, you've graduated to your K2 day and night. Then we might move them off the K1 entirely. Okay, so that just helps the patient to ease into the stage 2 appliance, rather than getting sort of immediately going from stage 1 to stage 2. Okay, now moving to the stage 2 appliance. So just as a reminder, the stage 2 appliance is for correction of the habits and also for arch development. So why do we need to use a stage 2? Okay, why use a stage 2? So this is especially important for those doctors out there who are just using stage 1 appliances. They don't understand why it's important to use a stage 2. What does that mean? It means inner layer. Okay, so this optimizes comfort while providing stiffness, which promotes arch development. So the appliances are nice and rigid, and they can promote arch development, but they retain comfort because of the silicon outer layer. They simultaneously, this is the great thing about the Myobrace appliances, unlike rapid palatal expansion or some of those other techniques that make the function worse, the second stage appliances simultaneously create more space while training and improving function. So you can see here, this doesn't get in the way of the tongue, but also it makes tongue function better through the tongue elevator and the tongue tag. So as you're getting that arch development, you're also simultaneously improving the habits. And then the expanded structure, so as you have the expanded arch form, it complements functional correction. So it's a positive spiral. So as you get more arch development, you get better habits. And as you get better habits, you get more arch development, and you get a positive spiral in the right way. Now it's at this stage here where we might consider the use of arch development. So we finish with our stage 1 Myobrace, and then as we're about to use the stage 2, we think to ourselves, do I need the BWS? Do I need the myolay? Do I need to use some sort of arch development to assist the stage 2 appliances? And it depends on how old the patient is, and depends on how severe the malocclusion is as well. So all those factors come into play, which your regional office can help you. We offer treatment planning services, and we can help you to determine whether you need more arch development or whether you can just rely on the Myobrace. So when do I move on from a stage 2 appliance? When both the upper and lower arch development is complete. So when the upper arch form is good and the lower arch form is looking good, when myofunctional correction is predominantly complete. So the patient's habits are 90 to 95% corrected. When there's enough room for the erupting dentition, so some doctors get a really nice arch form and beautiful teeth and they're all aligned, but they fail to realize that in the mixed dentition anyway, and it's in the primary dentition, that they fail to realize that there's going to be adult teeth that are going to be coming through. So we need to have more than enough room for the erupting dentition. That's very important. And the same tip applies as I gave you from K1 to K2, as does from K2 to K3, is 1 month before moving to the K3. You can issue the K3 for use during the day and issue the K2 for nighttime, and then transition them into full-time K3 use. Okay, now coming into the K3, which is the final appliance in the range. Why do we need to use a final appliance? It's made of the hardest material. It promotes retention of tooth position and the arch form, and it's used to provide final correction of a particular poor myofunctional habit. So let's say you've virtually corrected all the habits, the teeth are looking good, the arch form's looking good, and all you're doing is you're just trying to correct that lip seal, or you're just trying to correct that final bit of that swallow. You don't need to be seeing the patient every single month. You can just keep them in a K3, and then you can put them in a retention protocol, and you can just ask them to do some exercises to correct that. Finalizes and retains structural correction while practitioner finalizes habits and assesses stability of the teeth, arches, and habits. Okay, so as our retention protocol, we continually assess the stability of the case. Now, when do we finish with the K3? So that means when do we wean them off the retention appliances in total? So when all treatment goals are achieved, which is breathing, function, arch form, alignment, and stability. Okay, and as part of our retention protocol, and depending on stability, the patient gradually weans off as per our retention protocol. So read the retention protocol on the online course, MB0101. Go have a read of that, and it'll explain to you how we wean the patients off the Myobrace. So when is Myobrace treatment completed? So when do we finish with the stage 2 appliances and we issue a retention appliance? Is when all of these different metrics, or all these different requirements are met. So for example, the dental arches are developed to comfortably accommodate the erupting dentition and promote tongue and swallowing function. It's a normal state of dental development appropriate for the age. So like I said, we want to make sure that the teeth have enough space to come through. We want optimal function, which is stable. So we want lips together, breathing through the nose, correct swallow, tongue in the roof of the mouth. And we want to make sure that that's stable. It's not constantly relapsing as we're during the retention period. And we want exclusive nasal breathing with correct tongue, swallow, and lip function. Once we've got that, the patient goes into the retention phase. So guys, as I said, I'm trying to get through this so I can get to some of your questions. I'm just going to make mention of some of the other ranges that I haven't covered. You can find out more of this on the website. You can also read the appliance catalog. It has all the information that you need. We do have a series here called the J series, which is used in the primary dentition. So the primary dentition is a fantastic time to treat patients. There may be some difficulties with compliance, but what we typically do is we do a 6-month shortened program, and the 6-month shortened program will tell us whether A, the patient is suitable to continue, or B, sometimes you can even just get correction in 6 months because the kids are growing so rapidly. So it's a great way to, if you have any kids in the primary dentition, I recommend you do use the J series. We also have the Myobrace for Kids Broad. Now the Myobrace for Kids Broad, you'll see that on the website in the catalog. This is the exact equivalent of the Myobrace for Kids, but it's optimized for the East Asian arch form. So a lot of doctors will ask me, like, I've never heard of that. What is the East Asian arch form? If you look at our skulls, patients of East Asian heritage, many experienced dentists out there, they'll be able to look at some teeth and know whether a patient is of East Asian heritage or not. The arch form is completely different to what we call the Caucasoid arch form, the Caucasian arch form. The Caucasian arch form is mainly for Europeans, Middle Easterners, and so on. But the East Asian arch form is for people of, Chinese, Vietnamese, any Southeast Asian, Japanese, even some Latin American populations have this kind of arch form as well. So the arch form is much broader and it has a diverging posterior segments. So you can see here how the appliance shape mimics that arch form. Okay, so it's not trying to turn them into a U shape, it's trying to mimic that natural arch form. The reason for this arch form is that the tongue is a different shape as well. Okay, so the tongue isn't this shape, like the Caucasoid arch form. The tongue is a broader and flatter shape. So we want to create an arch form that's conducive to creating the correct habits, a habit correction, I should say. Okay, then we finish in the K3 just as normal. So I'm not going to re-explain. It's exactly the same as the K series. It's just optimized for patients of East Asian arch form. So if you see this kind of arch form, please consider using the K broad series. Now, sometimes doctors will say to me, oh, the arch form is so narrow, I can't fit a K broad in. That's fine. Just start in a regular K1. And then once the arch form is good enough to move into the broad series, just transition them to the broad, just like I mentioned before. So you can do that as well. Now, this is a new appliance range that we released. It was released last year. So in case anyone hasn't heard of it, we have a big audience here today, so I did want to just re-announce that. We've actually released the P3 series. We used to just be a single appliance. So we used to just have the single P3 appliance. That P3 appliance that we used to have has been rebranded to the P3H. Okay, so it's become the 3rd stage appliance in a 3-stage appliance series. Okay, and this is really for those kids who are in the late mixed permanent dentition, and we use the benefits of the P3, the 3mm offset, to create a better dental correction of class 3. So you can now start in a soft silicon appliance, the P3N, then you can move to the P3, which is a stage 2, and then you can finish off in the P3H. Some patients as well, they start in the I3N, then they go to the I3, and then they finish off in the P3H as well, just to get that final dental correction. So it's a fantastic range to use. I highly recommend you look into this appliance range. Now, often in these patients, because they're a little bit older, we do need to use the BWS, but not always, okay? So if you just have a slight edge-to-edge bite or something like that, you can use the P3 series. It's a fantastic series to look into. More information on the website and the catalog. Okay, now I did want to just show you guys this case report. I showed you in the last free webinar as well, but this was a case report that was published in the American Journal of Orthodontics that combined our T4B appliance, one of our older trainer appliances, with fixed orthodontics. And you can see this case here. This is how the patient started, and this is how they were 4 years follow-up. This isn't how they finished. This was a 4-year follow-up. Okay, you can see the doctor didn't use any fixed retention or anything. So you can get these sorts of changes if you combine our, this is another example of the T4B. So this was a case here. The patient couldn't close this, this patient kept relapsing into this open bite, and the orthodontist couldn't close the open bite. So by putting the braces on and combining with our T4B appliance, this closed in I think it was only a few months, May to June. Yeah, 3 months. So very quick closure here. So we can close the open bites, but not only is this limited to open bites, we believe in myofunctional orthodontics that all malocclusions have a soft tissue dysfunction component. So don't just reserve it for open bites. If you're doing any sort of braces treatment, please use what we would prefer to be the B series of appliances. So the B series of appliances, there's 4 appliances in total. So you have the B1 and the B1 lingual. The B1 is just for regular buccal braces. The B1 lingual is for lingual braces. The B2 is for use after expansion. So if you've sort of developed the arches using some sort of palate expander and you're looking for something more rigid to hold the arch, you would use the B2. And then the B3 is typically for retention with clear retainers. But like I said to you earlier, if the patient finds this uncomfortable, you can also just use the B1. That's fine. Now, what this does is while you're straightening the teeth using braces, it provides you with a myofunctional appliance that's going to correct those habits simultaneously. So what that does is it makes your orthodontics simpler, more effective, and more stable. Because like I said, at the moment, all around the world, people are putting braces on teeth. The tongue is pushing against the teeth. The cheeks are pushing against the teeth. You have a reverse swallow that's preventing those teeth from aligning. If you just put one of these appliances in, it'll deactivate all of those muscles, and it'll allow you to correct those teeth very seamlessly. Okay, so anyone doing orthodontic treatment, please look at using the B1 at minimum with your braces, okay, with your fixed orthodontics. Even clear aligners, you can put clear aligners and put a B1 over the top as well. It'll provide you with the same thing. So use simultaneously with braces and clear aligners. Okay, and this is just a quote out of the American Journal of Orthodontics, that it expands the arch form, improves oral muscle function, corrects mouth breathing, and also makes fixed appliances work better. Okay, so we can see here with the B1, sorry, this is the B1 here, there you go. So we've got the braces channels here that accommodate for braces. Some of the orthodontic practitioners out there might be thinking, oh, it'll also make the braces more comfortable because it creates a soft tissue barrier. So a lot of patients complain that the braces rub against their cheeks and cause ulcers and so on. So this will also make the appliance more comfortable, make the braces more comfortable. So if you're thinking that, you're absolutely right. And also it will position the lower jaw into a class 1 position as well. So you're getting that sort of functional appliance effect by bringing the lower jaw forward, but you're also aligning the teeth, and you're also correcting the habits, and you're also making the braces more comfortable. So it's really a no-brainer. Anyone doing braces, throw a B1 in. You don't even have to do any training. 1 hour a day and overnight, that's all the patient has to do. So an appliance that should be used with all braces cases. Okay, you can use it 1 to 2 months before your brace appointment. We like to do a 1 to 2 wire on. You can put the B1 on, or you can use it throughout the entire treatment, whatever you want to do. Positions the lower jaw in class 1, deactivates orofacial muscles while braces align the teeth, prevents soft tissue rotation from braces. Okay, now the B2, we got our braces channels again, but the only difference here is that now we have the inner cage. Okay, so we're still providing that Frankel effect. Leveling and aligning. So if you haven't even done arch expansion, once you've done the initial leveling and aligning, you can put the patient into a B2. It'll give you a bit more arch development. Or if you've put the rapid palatal expander in there, you can put a B2 in there to hold that arch form a little bit more effectively. You can use it when you progress to a strong wire, promotes arch development, plus all the same benefits of the B. So like I said, if you want to just use one appliance for the entire time using fixed orthodontic treatment or clear aligners, just put a B1 in. Just keep it simple. And for active myofunctional treatment, this was another new appliance we released last year, the TLJ for braces. So the TLJ for braces, you can see it's got our braces channels, so it fits over the top of braces, and it's got a number of features here that the patient can actually exercise to get strength and development in their orofacial muscles. So you use the B1 with your braces, and then for 10 minutes twice a day, you take the B1 out and you put the TLJ for braces in, and you're exercising the TLJ for braces. So you're getting active treatment and you're also getting passive treatment with the Myobrace. Okay, you can see here are our braces channels, and we've got a new lip bumper as well. All right, so I'm just going to go through these really quickly, guys. I went through it in the last webinar, but I'll go through them again. But what are the benefits of using the Myobrace appliances? So we get all of these things that I'm going to show you in a second. We can delegate a lot of the training to auxiliaries. So a lot of doctors will, sort of ask, like, how do I make this treatment more profitable? Well, you can delegate 80% of it to trained auxiliaries. So you hire your Myobrace educators, you train them, very easy to train them, and then you just delegate the treatment to them. And you can provide comprehensive myofunctional training with the Myobrace activities. It's used for 1 hour a day plus overnight, and it's used with traditional braces and aligners if needed. So I'm going to go through these quickly because I already went through them in the last webinar. But you can see here, improved mid-face development, improved development of the profile, which makes the airway better, improved upper arch form with no extractions, uncrowds the lower teeth with minimal forces, no fixed retainers, Class 2 correction, you can see here, this is the same patient. We get a Class 2 correction, but with the same system, we also get Class 3 correction. So for those that haven't seen the previous webinar, you might be thinking, how is that possible? Like I said to you, the indications of the appliances aren't based on the malocclusion per se. They're more based on the fact that the patient has incorrect breathing and myofunctional habits. So by correcting those causative breathing and myofunctional problems, we can correct Class 2 and Class 3 in the same system, because those are the things that are leading to the problem in the first place. Okay, we see here Class 3 correction here from the profile view. Keep in mind, this is 5 years after treatment was finished. Okay, so a lot of people say you need jaw surgery. If you saw this patient, you need jaw surgery. You don't. If you treat them early enough, you can get a nice result, and it can be maintained into the permanent dentition. Okay, opens deep bites, closes open bites, okay, and complements fixed orthodontic treatment. Okay, and we showed this slide here. And this was a pilot study published by Professor Levrini. He showed that the Myobrace Myoso appliances, the present results suggest that Myobrace Myoso myofunctional appliance can be used as an alternative to treat mild to moderate sleep apnea in children. So this was a pilot study. We're looking to replicate it on a larger scale soon. And this just shows you that we do get breathing correction using these appliances. Okay, so where to find more information? The Myobrace catalog, which you can find on our website. And you can go to the website, go to the appliances tab here. If you click any of the appliance pages and you go down to the bottom, you'll find the Myobrace catalog there. Or you can do our online courses as well. So if you click the online courses tab, like I mentioned, you can see here the course topics, click Myobrace, do the Myobrace course as well. Okay, so guys, I don't really have time to go through all of these here, but I just want you to have a look at the screen. We've got more appliance ranges outside of the Myobrace. It'll take us a long time to cover them all, but you can read about them on the website, especially those doctors out there who just want to be doing breathing and myofunctional correction for children without doing arch development, without doing orthodontics. Really be looking at the MRC for Kids range. That's a great series that allows you to provide breathing and myofunctional correction without orthodontic treatment. Doctors out there wanting to treat grinding, you can use a Bruxagard or a MRC for teeth grinders, same appliance. And you can also use a TMJ appliance for diagnosis and immediate treatment. So plenty of things to read about. Please go read about them on the website and look at the appliance catalogs. Okay. More information at myobrace.com. All right, and we released a whole bunch of new catalogs last year. So please check these out. They're on our website, or your regional office will have them. Don't have time to go through this today, unfortunately. I did want to talk about the myofunctional orthodontic evaluation, but one thing that I really want to mention that's important is making sure that you guys understand to look at the soft tissue dysfunction and look beyond the teeth, okay? So understand why the teeth are in the positions that they are. So it's important that you, sorry, I'm just gonna go back here. So it's important that you develop the skills to be able to evaluate the soft tissue dysfunction at any age, okay? So looking at these patients, you know, we have to understand that the problem is present in plain sight. You just have to be able to detect it. You have to learn how to see it. And also you have to understand that the problem is found in the majority of children. So some of the doctors out there who, I'm not sure that there's a marker for this in my clinic, more than 3 in 4 children have this problem. So the chances are if you're seeing children in your clinic, 100% they're going to be suitable for this kind of treatment, okay? So tune in next time at the next webinar. We're doing another free webinar on the MOE, the myofunctional orthodontic evaluation, where we're actually going to show you how to evaluate these problems, what the symptoms are. Otherwise, you can go on our website, learn to do it yourself. There's even a free course on our website. It's called the Introduction to MRC's Philosophy. Chapter 5, I believe, 4 or 5. There is a free chapter on evaluation. So go on there. You can actually download the MOE form from there. The MOE, by the way, if you can see, there's a little handout tab in GoToWebinar. You can actually download the MOE from that. Otherwise, speak to your regional office or go to the free online course and download that from chapter 4 or 5. Okay, so guys, I'm gonna unfortunately have to cut it off there. So that was pretty much most of the presentation. So here are the contact details for your regional offices. Now I've got some questions here in front of me. I'm gonna try and get through as many as possible. I might just have to run 5 minutes over time. So if you need to go, feel free to go. You can watch the replay after this. But if we don't get through your questions now, what I'll try to do is respond to all of these after the webinar. Okay, so we'll forward them to our regional offices so you can get an answer to your question. So I am going to go through these and make a mention. So even if I answer your question, I'm going to answer them more comprehensively after we touch base with you. So I'm going to go through and just give you some guidance on where to get more information. So the first question I have here is sizing and myofunctional exercises simplified for busy dental, TMD, and sleep practice. So if you're a busy clinic, if you may not have heard, but last year we launched the Fast Track activities program exactly for this reason. So some clinics are busy and they're caught up and they don't want to do the full activities program. That's fine, even though we recommend doing the full program to get the best results. You can actually implement our Fast Track program. So Fast Track programs, it uses our MyItalia appliances and simplifies the activity program right down. So it's perfectly suited for busy clinics, private clinics, and so on. Does Myobrace work for special needs kids like autism that has an overjet? So the special needs in itself doesn't impact whether the Myobrace works or not. It'll work for anyone, special needs or non-special needs. The only thing that may be an issue is sometimes compliance in these children can be more challenging. So one thing we like to do, if in the kids who are younger, if they can't sort of adjust to the Myobrace program or they're not compliant with the Myobrace program, you can look at using the Myo Chew appliance. So the Myochew appliance is perfectly suited for children with special needs. It's just an exercising appliance. It's fun for them. It has bristles to clean their teeth. So it's a really good sort of appliance to use for those kids that can't comply with the Myobrace program due to their special needs. So treat special needs kids like any other child, but if they struggle with compliance, there's other things you can give like the Myochew so they at least have something to use. Okay, so at what age can a patient start using the Myobrace? Are there any contraindications? So the youngest kids that we've treated are 3 years of age, and I mean, there's nothing stopping you from treating a 2-year-old if they're big enough. The age itself doesn't quite matter. It's mainly whether the appliances fit. So the Myobrace for juniors typically fits in a 3-year-old, so anywhere from 3 to 5. If the child is younger than that, you can start with a Myochew, have the child use the Myochew until they're old enough to get into the J series, and then put the J series in. So ideally, we'd like to treat these problems as early as possible. So as soon as we see the problem, we like to treat them. It's just a matter of whether we can get compliance and the appliances can fit. So that's just something to keep in mind. Are there any contraindications to Myobrace? So the only real contraindications, just remember, Myobrace is very safe. If the Myobrace is not being tolerated by the child, they just spit it out overnight. Or the Myobrace is not stuck in, it's not glued in, so it's removable, you can take the appliance out. But the only real contraindications are if the patient has a severe nasal blockage to complete nasal blockage, I should say, that means they can't breathe through their nose at all. It's not so much a contraindication, it's more so that the Myobrace can't be retained. So you're gonna have to work with an ENT arm, block that nose. The other sort of contraindications would be like if the teeth are loose for whatever reason due to periodontal problems, not so much loose as in they're exfoliating, but more so loose for periodontal problems and so on. You don't really want to be moving the teeth in that sort of environment because it can cause more issues. But besides that, there's very few to none, no contraindications with Myobrace. What are the Myobrace appliances suitable for 3-year-old with class 3 malocclusion? So for a 3-year-old, you can try our first line of appliance that we like to try is the i3N small. So we like to stick with the class 3 appliances and use the small ones. But if that doesn't fit, we've also used the J series. Because the children are so young at this age and they're growing so rapidly, you can get away with not using, I should rephrase that. You can get away with using the J series because the children are growing so rapidly that you don't need those specialized features of the i3 range. Although it would be preferable and the case would progress more effectively, if you are having trouble fitting the i3N small or you don't have one, you can also use a J1 and then move through this sequence. So J1, J2, and then J3, or you can go i3N, i3, i3H in small size. Okay, we have another thing here, open by crooked smile, tucked chin. So hopefully I've answered today that it's not so much about the malocclusion, it's more so about the stage of dental development. So it doesn't matter what the patient has, it just matters what age they are. So if they're in the mixed dentition, use the K series, developing permanent, use the T, and so on. And at what age can a child start using the Myobrace? So I answered that before. Please discuss factors in case selection. So you can learn more about case selection on our catalog. So go through the catalog, it tells you about the case selection, but hopefully today I've outlined that it's mainly got to do with the stage of dental development. And the only time that doesn't apply, or it applies to the malocclusion, is when you're talking about class 3. Everything else, it just applies to stage of dental development. Why is that? Because we're correcting the habits, we're not correcting the individual malocclusion. You correct the habits, you get all those changes that we went through just before. Any recommendations for a young child like 5 or 6 years old with rhinitis wearing the Myobrace during sleep? So yes, if the rhinitis is, sometimes wearing the Myobrace helps to improve the rhinitis, but most often than not, you need to cooperate with the ENT, the GP to control the rhinitis. So what we recommend is just going through the regular, allow the doctor to make the recommendations, but medications, steroids, nasal sprays, sometimes immunotherapy, whatever works for that child. Try to get that sorted because you need that airway clear so that they can breathe through the nose. Okay, this might have to be the last one. Any tips on how to keep the lips closed over the device? So I assume this means overnight. Don't worry about that in the early stages of treatment, okay? So sometimes lip closure is the last thing that happens. Just remember when they wear the Myobrace, it's pretty much simulating the lips being closed anyway overnight because you can't really breathe through your mouth if you're wearing the Myobrace overnight, if it's staying in your mouth. So in terms of keeping the lips closed over the device, The main thing to work on is the day wear. So when the child is wearing the Myobrace during the day, get them to hold the lip trainer between their lips to make sure that the lips are being closed. And you're getting that lip training during the day, and then at nighttime, the lips should start to close more and more. But don't worry about that so much. As long as the child is breathing through their nose, that's okay. Remember that the Myobrace is designed to pry the lips apart, because during the day, the child will close their lips over the top of the appliance and it will train the lips. It's meant to be difficult to close your lips over. It's a training appliance. If you're speak to your practitioner about, well, sorry, I should be talking to a practitioner. So make a determination about whether you want to use something like tape. We don't really recommend that too often. We do like to get a clearance from the ENT before we consider things like tape. But just remember, the tape isn't fixing the problem. The tape is sealing the lips together. What you really want to do is you want to have the child closing their lips over the appliance. When you get to the end of treatment, so when you get to like the retention appliances, because they're a thinner profile, the child will be able to close their lips more effectively over the top of the Myobrace. So don't worry about it in the early stages, continue with treatment, and you'll get that corrected over time. Okay, so guys, I better wrap it up here because we've just gone slightly over time. So just want to give everyone reassurance. We will try and get back to every single person with their questions, and we'll try and support you every step of the way. Remember, all of our regions, as you can see here on the screen, the contact form, all of our regions provide one-on-one support. Any questions that you have, just contact our region. We've got trained educators on the standby. They can answer any of your questions. So don't be guessing. Ask us. We'll help you every step of the way, making sure that you get good results with the system. All right, guys. So with that said, thank you so much for your time today. I really appreciate it. It's a fantastic turnout. And we really hope you got something out of the presentation today. For those of you who this was more of a revision for you, please remember, go to our website, do the online courses, contact your regional office for support. Ask them about some of our new resources that we've released last year, for example, the Fast Track, new appliances, and make sure you read the appliance catalogs as well, very important. With that said, guys, thank you so much, and we look forward to seeing you at our next webinar, which will be on the myfunctional orthodontic evaluation. Thank you very much, and I hope you have a great day.